Thanks, honey. I have to change,
Yeah.
it's okay.
See, look at your image and see if it's better with this light too. Yes or no?
Do it out. Do it again. I guess the light is better. I'm only on there for a minute, but okay, leave it.
Okay. I'll have to come get her at some point.
Yeah, that's fine. I'm literally just introducing and then I'm out.
Oh, okay.
Yeah, I just have to get them going.
Some coffee.
Did you want it to already be recording?
Me?
Mm-hmm.
No, we don't start, not yet, but thank you for reminding me. No, we don't start it, we don't do this part where we chat.
But it is recording right now is what I'm asking.
Oh, no, we don't want to be then. Okay, hold on, let me stop. Okay, we're gonna begin to record and I'm admitting folks. Good morning, everyone. Good morning. I'm so sorry everyone had to wait a little bit. Apologies. Because we lost some time in technical difficulties, we're not going to do our usual overview. I'm just going to ask Tess to do a land acknowledgement, and then I'm going to move straight to Steve to introduce this incredible training. Hopefully you took your good minutes while you were waiting. Okay, Tess, can you do our land acknowledgement for us, please?
Yes. So before we begin, we want to acknowledge the painful history of genocide and forced removal of the Nipmuc, Massachusetts, Agawam, and Pawtucket people from their land. And we honor and respect the diverse Indigenous people that still live here and that on the land that we work and that we live. And one of our hopes at Wayside is to commit to gaining awareness of this land's history and Native people. And we are happily building some relationships with specific people from different tribes at the moment. So hopefully this will continue forward.
Thank you so much, Tess. We will let you know more about the work we're doing around supporting First Peoples in an anti-racist article soon. In the meantime, Steve, take it away. Welcome, Steve and Dr. Simon.
Good morning, everybody. Thanks for joining us for today's training. For those who do not know who I am, I'm Steve Delbanco. I'm the agency's Substance Use Intervention Coordinator. I've done consultations with many of you and trainings with others. And I really appreciate the time all of you are giving to this issue. To clarify who I am, my first question is, how many therapists does it take to change a light bulb? Anybody know? The answer is 1, but the light bulb has to want to change. Wayside began its substance use initiative about 3 years ago to address what we all saw as a growing problem with substance use with the kids that we work with and the families served by Wayside. I'm excited to report that we've made pretty good progress in a number of areas. Recently, the data shows that 80% of clients between the ages of 12 and 25 had completed a craft as part of the assessment and is included in the client record. The use of the screen tool has become very much integrated into what we do as part of the assessment process. Thanks for that. I really appreciate it. As a reminder, when youth or young adults score 2 or more, there should be a consultation with me. I promise that I won't say any dad jokes during the consult unless you request them. I'm also happy to talk about clients or families, even if there's not a completed craft screening, or if the screening was a 0, or if any of you suspect significant concerns, possibly with a client's older sibling or family members. I've done, many of you will know, I've done consultations directly with clients as well, if that's what's needed. We're just trying to do whatever we can to address the issue. Another aspect of the initiative, obviously, which is why we're all here, is that we've done a lot of ongoing trainings. As many of you remember, last year we had 2 trainings, one on multi-generational substance use and harm reduction, and a second that was focused on the use of motivational interviewing to address substance use. Today's training is about the intersection of anxiety and substance use disorder. I'm thrilled to introduce Dr. Kevin Simon, Wayside's medical director, a man who has more jobs today than I've had in my lifetime. Dr. Simon is a board-certified psychiatrist who has completed additional fellowship training in child and adolescent psychiatry and addiction medicine at Boston Children's Hospital and Harvard Medical School. Dr. Simon's research and writings on health, inequity, race, social determinants, and substance use have appeared in many notable journals, including the New England Journal of Medicine, Health Affairs, Health Equity, and Psychiatric Services. He regularly presents at national conferences and has been featured on media outlets including ABC News, Forbes, and NPR. In addition to his role as medical director at Wayside and his work at Boston Children's Hospital, Dr. Simon is also the Boston Health Commission's first ever Chief Behavioral Health Officer, implementing a comprehensive behavioral health agenda for the city through a public lens. Anyway, he's a busy guy, and we're happy to have him today. Dr. Simon, it's on to you.
Yeah, no, thank you, Steve. And from the comments in the chat, your jokes are like hitting spot on. So thank you to everyone that has joined, 170 plus people. And we're gonna make this engaging. This is a very long time that we're going to be together. So if you want to take yourself off mute, that's completely fine. If there are babies in the background, that's completely fine. If there are kids in the background, that's completely fine. Dogs, cats, even eating oatmeal, it doesn't matter. Like, really be comfortable because we're going to be spending a lot of time together. And I will share my screen. And actually, even before I share my screen, given that we're going to be talking about anxiety, you may have recognized that at the beginning of this, our host felt some anxiousness. Like, oh, we're going to rush through and just jump to Steve. Let's acknowledge things happen, technical difficulties happen. And Allison, Amy, thank you for working with us through this technical difficulties. All right, so here is, and full screen. And I am on campus and there is landscaping happening. So if you also can't hear me at some point in time, please just take yourself off mute and be like, Dr. Simon, we can't hear a darn thing you're saying. I really want this to be engaging. All right, so first I should broad disclosure. So my worldview and understanding are shaped by experiences. I have implicit biases, we all have implicit biases. I'm the product of many things, seen and unseen. But I do try to stay in a learning frame and I do try to stay open-minded. If I say anything that in some way, shape, or form offend somebody, please, in the moment, put it in the chat, say, hey, Dr. Why did you say that? Or you can email me, that's completely fine too. In terms of disclosures, these are disclosures as the good sir Stephen mentioned. There are a lot of places that I kind of exist. In reference to today, we're going to talk about the neurodevelopment just of adolescence, impact substance use has on it, highlight some substance use epidemiology, and try to distinguish between substance-induced versus quote-unquote organic anxiety, and then discuss evidence-informed or evidence-based screening, assessments, and treatment. And then how is it that we're going to get families, let alone the youth, engaged in this broad treatment? So before we even do that, I do want to touch on language that is important. And so, there's a lot of things that we say when we're talking about substance use and talking about individuals that have these types of challenges that are stigmatizing, and we may not even recognize it's stigmatizing. So substance abuser, drug abuser, alcoholic, addict, user, abuser, drunk, junkie. That's not how we really want to talk. Try to do, first person oriented language. So a person with a substance use challenge or a substance use issue or a substance use disorder. Referring to addiction really should be severe substance use disorder. And I know I'm being very pedantic here by emphasizing the shift that the DSM-5 has had, but it is appropriate. So we have risk of use or risky use, unhealthy use or heavy use, persons in recovery, and then not drinking or not taking a substance or a drug. And then in reference to my psychiatry colleagues or nurse practitioner colleagues, positive or negative urine tests, not dirty. And then specific to opioid use disorder, even I technically don't like mode medication for opioid use disorder. Because we don't say, well, insulin is medication for diabetes. We just say it's insulin, right? So the hope here is just to have first person language and kind of avoid any negative associations. This idea of blaming individuals for circumstances that sometimes they have no actual control over. So in terms of adolescent neurodevelopment, so if I were to ask you, well, when does adolescence start? Many would potentially say, oh, puberty. It's a physiologic start point of adolescence, and puberty is shifting to younger ages. And then this idea like the end of adolescence, supposedly when people become adults, it's actually a social phenomena. And then the example is my parents are in their 70s. And when they got married back in 74, 75, the average age of like first marriage as one like proxy for adulthood was 23, 24. And the average age of first marriage now is 29, 30. Back then, pre-Affordable Care Act, you could not be on your parents' insurance until 26, but you can now. So I'm referencing this because when we're talking about particularly transitional age youth, so anyone who's working in any of our transitional age youth programs, this for sure. Persons who are 18, yes, legally per like statute, they're able to make some medical decisions, yet you entirely recognize that they still feel like a true adolescent and not yet an emerging adult. So it's just important to kind of recognize that. And when we think about brain development, we have this idea that even this is technically inaccurate. Like it's around 24, 25 when our prefrontal cortex, i.e. if you put the palm of your hand on your forehead, that is where our executive functioning comes in handy. And we have this idea of sensitive periods in relationship to substance use. And the sensitive period is adolescence. So if you hear about somebody who's engaging in vaping of some sort and they're 12 or 13, we really have to do as much as we can to try to shift that trajectory. Because there'll be information I share later about what it looks like if someone engages in substance use early on versus later on in their life. And substance use and addiction really is a chronic condition, and it really does often begin in adolescence. You can see here, age at cannabis use disorder, and this was for DSM-4. You can see 10, right? 10 to 25, that's the peak. And so that's our client population or patient population, depending on the term that you like to use. And so it's really important to be able to recognize when substance use is happening. And why is it that it's really important to try to intervene earlier on is our rational brain, the prefrontal cortex, it gets online much later than the reward part of our brain. And so when you give things like nicotine, cannabis, and other substances, alcohol, the reward pleasure part of our brain, it kind of gets rewired to not really understand what usual reward should feel like. And so when people are adolescents and they're in school, it's so difficult to suggest to themselves, let's wait 6 months for this good outcome, because 6 months to a 14-year-old is like 10 years away, versus vaping, quick inhalation, and they get a reward. And again, we'll dovetail deeper as we go on. We have a long time together. Teen reward is either go big or go home. So I have 2 kids. They are 5 and 2.5. And right now, if I told my 5 or 2.5-year-old, daddy's gonna come home with cookies, so you gotta be good for mommy, the cookie is enough that they might actually be quiet for mommy for 5 10 minutes. And they'll just ask, oh, when's daddy coming home? A teen or an adolescent, cookie is not enough to say, hey, this is why you should do your homework. This is why you should talk to this guy, Steve, or talk to this guy, Kevin, right? The reward has to be big. And unfortunately, when, again, you introduce substances, you shift how you actually perceive rewards. And so again, it's really important to be cognizant of that. And I see notes, oh, someone just says, bless you. Tanisha, bless you too. I try to pay attention to the chat while folks are, while we're here. So if you put anything, I'm gonna acknowledge it. So let's look at anxiety disorders. And anxiety disorders generally are a childhood condition. And anxiety disorders are the most common mental health condition. So more prevalent, more common than depression, more prevalent, more common than mood disorder, more prevalent, more common than schizophrenia, bipolar condition, even more common than, yes, substance use disorders. So you're going to see it. Lifetime prevalence, 8 to 27%. So basically a quarter of people that you engage with, not even quarter at Wayside, but just a quarter generally, are going to have some kind of experience of anxiety that could be clinically requiring some kind of intervention. Social anxiety disorder is actually the most common. So that idea when the client suggests that, they don't want to go to school, they don't like reading in front of class, they don't like participating in activities with others, it's likely true. It's the most common anxiety condition. Now, generalized anxiety does have an estimated prevalence of about 15%. So it too is common. And anxiety in general is reported more in girls. Now, I here have a point to make. People just acknowledge girls' anxiety more often. But I'm not really sure that I could say, particularly engaging with many youth, that boys are less anxious. It comes out differently. But our literature would suggest that it's reported more in girls than it is for boys, with an average age of onset 8.5 years old. And then most pediatric anxiety disorders co-occur, i.e. this idea of a triad: social anxiety, separation anxiety, generalized anxiety, often happen together. And pediatric anxiety disorders are associated with what? Why is this important? Well, school performance, generally down, peer relationships are negative. And if left untreated, pediatric anxiety disorders tend to persist into adulthood. They don't just go away. And so you're increasing your risk for depression, you're increasing your risk for substance abuse, you're decreasing your likelihood of occupational impairment, i.e. you probably won't be able to engage in work as easily as your peers. And then actually there is increase in suicide ideation, suicide attempt. So if not for anything, treating anxiety is important, irrespective of whether or not substances is engaged with the anxiety. So when you see that patient and you're engaging with that family, you're in the house, we really should be trying to manage and help them manage their anxiety conditions, because also anxiety is a normal part of existence. I can tell you, Allison was experiencing anxiety this morning. Like, oh my gosh, it's 9:32. There's so many people in the waiting room, and she couldn't hear me because the mic wasn't working. And I wish I could just say, Allison, just breathe. It's going to be okay.
And I
Right.
was texting Beth Chin going, deep breaths, while I was trying to manage my anxiety. So
We all experience it. And here's what it really looks like. We're all basically Venn diagrams that most 35.9% have a combination of these issues. And if you recognize anything that I'm saying, again, put it in the chat. We want to be engaged this morning. And in terms of the comorbidity, it's the rule, not the exception, okay? It is the rule, not the exception. it is very actually rare to meet someone supposedly with just, only social anxiety. And more than half of patients or clients have more than one anxiety disorder. And the odds of experiencing anxiety and depression are pretty good. Attention deficit disorder, attention hyperactivity deficit disorder, ADHD, very common. And then opposition defiant disorder, very common. And so these are just statistical ratios just highlighting how prevalent they are together. And here's generally the trajectory for having an anxiety disorder. So trajectory 1, spontaneous long-term remission. Out of nowhere, you had separation anxiety. And full disclosure, I had separation anxiety growing up, i.e., I knew I wanted to play with my cousins. They had always the better video game system. So I had Genesis, they had PlayStation. I'd go to their house, and 10 o'clock, I'd start crying because I want my mommy to come pick me up. And yes, so that's separation anxiety. I know I want to be with them. While I'm there, I'm playing and engaging. It's going well. Then I realize, oh, shoot, I'm not where I actually want to sleep. I don't care if we're in Long Island and my parents are in Brooklyn. Please drive back to get me. And spontaneous resolution, that is a trajectory. Then we say strict homeotypic continuity, i.e., your social anxiety or separation anxiety actually persists into adulthood. Trajectory 3, broad homeotypic, i.e., separation anxiety in child predicts panic disorder, that's PD, panic disorder in adulthood. And then trajectory 4, sequential heterotypic, i.e., your social anxiety in childhood, as an example, predicts later life mood disorder. So social anxiety turns into major depression disorder, in part because you recognize, why can't I do these things that other people are doing? Why can't I, even knowing I have anxiety and maybe I'm kind of engaging in cognitive behavioral therapy, I still yet can't get over it, and I become reclusive. I lose luster for the things that I do enjoy, and that translates into a major depressive disorder. So generally, there are multiple trajectories in terms of anxiety conditions, and I'm just going to the chat. And oh, this is beautiful. Do these observations apply to trans youth as well? Yes, they do. If so, do they show signs of their gender they transition to and their sex? Oh, Gerard, these are great questions. And again, I apologize if I'm pronouncing anyone's name. Brianne, apologies. You can come off mute also, just say Dr. Simon actually is pronounced this. So
yeah, no, you corrected Gerard, right?
And it says here, I'm wondering if girls being diagnosed more than boys is a result of social cultural influences imposed on them from an early age, along with presentation that is influenced by the same. Yes, this is true. It is more common to understand that, quote unquote, girls can be open about their emotions, less so for boys, less so for persons of color, less so for sexual gender minorities. So yes, unfortunately, our socio-cultural environment does predict who gets access to services and who does not. So approximately 1/3 of individuals will just have spontaneous remission of their anxiety disorders. 1/3 it will persist, and then 1/3 remits from anxiety, develops into other conditions. So let's actually look at generalized anxiety disorder, the DSM-5 criteria. So 1, excessive anxiety and worry, apprehensive expectation occurs more than not for at least 6 months. So it is a pretty extensive period of time. Yet I can tell you, by the time you meet somebody, for instance, if somebody is in a transitional age youth home, well, you're like 17. They likely have had anxiety for a decade. Most of our psychiatric conditions, unfortunately, do not get addressed appropriately, and there is a decade-long delay. So if you're engaging somebody that is an adolescent, they've likely had anxiety for an extended period of time. And the individual finds it difficult to control their worry and what it is that they're worrying about. The anxiety and worry are associated with 3 or more of the following 6 symptoms. So they just need 3 of these. And only 1 for children. When I say children, i.e. those who are under 13. And so restlessness or feeling keyed up on edge, being easily fatigued, difficulty concentrating, their mind just quote unquote going blank, irritability, muscle tension, sleep disturbances, difficulty falling asleep, staying asleep, or unsatisfying sleep. And so often when I'm engaging with a family and I say, oh, let's talk about sleep, there's basically 3 phases. You got a problem going. How long does it actually take you to get to sleep? Do you have a problem staying asleep? Are you getting up multiple times throughout the night? And then are you potentially waking up just extra early and not feeling like, oh, I got 7 hours, but how come it does not feel like I got 7 hours? So in the disturbance, if we're talking about just pure anxiety disorder, and this is where it gets complicated doing the work that you do. Here it says in the number 5 or letter 5, the disturbance is not attributed to the physiological effect of a substance. But here it is, I'm talking about, or will be talking about, substances impacting anxiety. So it is difficult at times to do the whole chicken and egg about which one came first, but we'll also talk about that. And Teresa, can I speak a little more to why we only look at one item in children's sleep? Yes. Well, in theory, if you have somebody who is less than 13, this idea of being easily fatigued or difficulty concentrating, mind going black, irritability, muscle tension, is actually pretty difficult. In part, this criteria was validated on adults. And so the idea that you're going to ask an 8-year-old, but are you easily fatigued? Well, it's like, well, what does that even mean? You got to ask some other questions, probably of the parent. And so we give, I guess, grace and credence to, if the youth is able to identify, and again, youth here being 13 or younger, identify one of these things, then it's a good chance that they actually are experiencing anxiety. And then also, again, when we get the parent information, so again, the social anxiety or separation anxiety, i.e., again, I'm talking about 13 and younger. I can tell you an 8-year-old that I have as a patient, going to sleep and the transition to sleep is like so difficult for the family, i.e. the youth will come to the room many, many times. And it's like, oh, mommy, one more read. Oh, I got to use the bathroom. And so it's like, okay, it's clear that they're not going to sleep readily, easily. And it's clear that they are feeling tense, right? So when you actually engage with the family, you probably are going to meet more criteria, but if you just ask the youth themselves, they just kind of need to just reference one of them. But that is a beautiful question, Teresa. And then let's talk about panic disorder. So recurrent, unexpected. So key here, unexpected panic attacks. A panic attack is an abrupt surge of intense fear or intense discomfort that reaches a peak within minutes, and during which time 4 or more of the symptoms listed are happening. And this notion of within minutes is very important to try to distill if you have, let's just say middle adolescent or emerging adult. In part, time itself shifts when you're experiencing anxiety and when you're experiencing a panic attack. And so what might feel like, oh, it was a whole hour, might actually have just been 10 minutes. But during the attack, time is distorted. And so abrupt surge from a calm state and palpitations, pounding heart, accelerated heart rate, sweating, trembling, shakiness, shortness of breath, feeling like this sense of like you're being smothered, I'm going to die. And this is where, if you're like an adult, it's actually interesting where that impending doom is both for heart attacks and also for panic disorder. So it's very unlikely that a 15-year-old is having a heart attack. So when they say certain things, we kind of key into, oh, wait a minute, that's potentially anxiety that we're talking about. So chest pain, discomfort, nausea, abdominal pain. It's Monday. I don't want to go to school. I have a headache. Like, really? Do you have a headache? It's Monday. You didn't have a headache yesterday. You didn't have a headache Saturday. Oh, but Mondays, man, the headache comes on, right? So we call it somatic symptoms. Feeling dizzy, unsteady, lightheaded, chills or heat sensations. Feel like you're losing control. Am I going crazy? Paresthesias, numbness, tingly, right? So you need 4 of those to happen during the attack. And again, as with most of our conditions, can't in theory be attributed to the substance, i.e. if a substance is on board, for instance, alcohol use, and that's happening chronically over time, and then you abruptly remove the alcohol, well, you're going to experience many of these things. In part, you might be experiencing delirium tremens, but we'll talk about more of that as we move forward. So scope of the substance use problem. So sorry, my mouse is very sensitive. So US prevalence of mental health disorders and association with co-occurring substance use disorder. And this is not in the general population, not just for you, but anxiety, again, is the one that I say is most common. General population, 28%. Prevalence in co-occurring substance use disorder, basically the same 20+%. Major depression and substance use. Now, it's notable, there's less individuals in our nation that have a major depressive disorder, yet those that do, good chance that you should inquire about substances. And then those that you meet that have substance use challenges, you definitely should screen for depression. And then the other SMI or serious mental illnesses, as is often framed, schizophrenia, bipolar, PTSD. And so you'll note here that for schizophrenia, the range on the substance use is very wide. The range on the bipolar is very wide. The range on PTSD is very wide. And so it's interesting, I've had a patient, 19 years old, and initially they presented to our substance use clinic, in part because of engagement in cannabis, engagement in alcohol and other kinds of substances, but came to then, through our interview, recognize that, oh, actually the substances really pair well during manic episodes. And so yes, during manic episodes, you are much more disinhibited and far more willing to try any number of things. Random pill, sure, I'll try it. And so you got to recognize the timing, and this is where our evaluations are super critical about getting that timeline over time. And in terms of alcohol use disorder and anxiety, again, very common here. And so what we're looking at here, for instance, specific phobia, social phobia, generalized anxiety, panic disorder, alcohol abuse, in terms of the odds ratio, anytime you see 1s, 2s, and those that are bold, it's a strong correlation. So again, if you see or hear about substances, you should likely ask about anxiety. If someone has anxiety, you should likely ask about substances, which is broadly to just say you should screen everybody. Now, this is interesting. The next 2 graphics I think are interesting, although I'm biased towards myself, so obviously I think they're interesting. All right, substance use increases 400 to 1,400% over a 9-year period. And I'm just looking at the chat. In the question from Kat Chadwick, do you know the statistics for how prevalent anxiety is in children who grow up in homes with emotionally unstable or abusive adults? I imagine that breeds anxiety in children trying to manage their parents' reactions. Kat, if you text me, I would have likely sent you a bullseye meme. Yes, it is high. And we know that from studies that look at quote unquote ACEs or adverse childhood experiences, those with higher ACE scores do identify with having higher anxiety. So you are spot on. So from 12 to 21, substance use skyrockets. And interesting enough, after 21, substance use actually significantly decreases. And so this is where, if we could delay the use, it's actually really helpful. In part, the older that you are, the more cognitive functioning that you have, executive functioning, You then understand, okay, you know what? It's Wednesday, we got a training. I'm not going to take that drink, smoke that doobie, use that vape, because I should be engaged with the session. And I'm gonna wait till Friday after 5 o'clock or whenever the weekend is for you to engage in that thing. But if you start to engage early, your understanding of social norms just shift and you can't wait for certain rewards. Now, there's many slides I'm going to show. However, if you could remember this one and you remember nothing else, I feel like we've done a good job. So the younger you start, the longer there will be engagement with a substance. So the way to look at this is we tracked, and when I say we, there's longitudinal studies that look over time. And this x-axis 0, 5 years later, 10 years later, 15 years later, 20 years later, 25 years later, 30 years later. Age at first use, under 15 years old. Age at first use, under 15 years old. 30 years later, 60% of those individuals are still engaging in substances in not appropriate ways. Under 15, you identify somebody as doing something under 15 years old. 30 years later, when you're probably no longer working with them, there's a good chance greater than half of them will still be engaging. If that shifts just to 15 to 20, 30 years later, 30% are still continuing to engage with the substance. And look how significantly it drops if the age at first engagement is actually after 21. 30 years later, only 10% of those individuals are still engaging with substances in inappropriate ways. So the clientele that you see here at Wayside is the first two, either under 15 or 15 to 20, more often than not. So it's just so critical that we intervene and try to help them understand this long-term trajectory. But I already told you reward pathways shifted. They're not thinking about 30 years from now, but we have to be thinking about 30 years from now. So neurobiology and substance use. So associated risk factors. So we have a lot. And somebody posing the question. Does this engagement with substance include non-problematic substance use? I'm going to say PAM, although I could be incorrect. But this is a great question. So question is, does this engagement with substances include non-problematic substance use? Now, I would just say, I'm uncertain of a city, a state, or any municipality that allows substances legally to be used by persons who are under 18. Right? Like, now, that's not to say that there aren't people who are 15 who have engaged in the substance and don't subsequently develop a substance use disorder, right? But I'm trying to talk about the general body. And so self-disclosure, I'm Haitian American, classically around this period of time in the year. We have something called cremas. It's kind of like eggnog, but it has some like rum in it. And have I had cremas around Christmas time before I was 18? Yes. But I was not having cremas in February or in June on a random Tuesday. So the notion of like non-problematic substance, this is where it becomes very individualized and you need to ask and inquire. And if we got a 16-year-old that has told you within the year, you've done the craft, they're in driving lessons and they're getting high or drinking alcohol and driving, that's not safe. That's problematic. They may not have had an accident yet, but that's problematic. So when we think about quote unquote non-problematic use, we do have to start asking some more detailed, nuanced questions. But broadly, if we're looking at a public health level, we got to try to mitigate engagement of substances for persons who are under 21. We know that it happens. We definitely know that it happens. And we know what the long-term consequences are. And here's further engagement. I suppose I mean across the lifespan, like a person who started using under 15 continues to use substances only in problematic ways into adulthood. But she's noting, thank you. So again, not saying that recreational use when somebody is 21 isn't appropriate, but we're talking about those that are engaging with the substances in inappropriate ways, such that they're, and as we're going to eventually talk about the criteria, and so I will highlight some of this later. So peers, parents, yes, Marie, Haitian Crown is great. Individual, biological community, psychiatric conditions are all risk factors at different levels. And this is a busy slide, but the way to just kind of look at it is we do have structures in our brain that are priming us to want to engage in substances. It's priming us. Now, the fact that I've talked about cremas, my mouth is watering just a little bit because I like it. And this is what happens when you talk about substances, right? So you get this preoccupation and anticipation phase. This is the green. Then there's the binge and intoxication, engaging with it a little bit too much. Then you recognize for some reason, "Oh, I shouldn't be doing this, I'm gonna stop." And then you get withdrawal and negative affect. So now I don't have the substance, my mood is down. And we're gonna talk about why it looks that way. So our substances aren't just like acting within us, not really doing anything. They're actually engaging with many of our neurotransmitters. So alcohol engages with GABA and glutamine. Dopamine is the reward neurotransmitter. And so kind of all of our substances do something to dopamine. Benzodiazepines, so like clonazepam or lorazepam, i.e. Ativan, react with GABA. Cannabis, anandamide. Hallucinogens and MDMA, serotonin. Nicotine, acetylcholine. Opioids, endorphins. And PCP or ketamine actually with glutamine. And Jess Diaz, I appreciate it. What about children who have been exposed to substance abuse pre-birth? So the intrauterine period. This is a great question, Jess. Can these disorders be reflected during the growth and development? Yes, we do recognize that those who have intrauterine exposure are at greater susceptibility of being born, for instance. So I'll speak to opioids in this case. There is something called neonatal abstinence syndrome, i.e. the mother was engaging in opioids, and we recognize that at birth, there are interventions that we need to do to stabilize the now neonate because of the exposure that the intrauterine environment provided. Fetal alcohol syndrome, right? Individuals that have that have a certain dysmorphic figure to themselves. And those that have intrauterine substance exposure are much more likely to actually experience, broadly, I'm just gonna say behavioral dysregulation, whatever that means. But yes, greater susceptibility for autism spectrum disorder, greater susceptibility for ADHD, greater susceptibility for anxiety disorder. So the intrauterine period is critically important, but there are interventions and there are clinics. So I'll talk about Project Respect, I believe is the name of it, at Boston Medical Center. It's catered to what we call high risk OB, mothers who are engaging in any number of things that would not be ideal for the fetus, and trying to get them management and treatment. But to answer the question succinctly, yes, youth and neonates that are exposed to substances early on, there is greater risk. And Daniel, quick question. What's your projections and increase in substance use resulting from legalization of cannabis? There's actually great data here. It's still mixed. So the best evidence that we have, for instance, Colorado is there a higher percentage of individuals who are adolescents using cannabis in Colorado? Some years, yes, but then some years, no. So we're not sure that directly one-to-one correlation. And despite the fact that I'm talking about substances a lot, there are ways to use substances in the policy realm for good. I'll give you one example. Evanston, Illinois. Now people will Google Evanston, Illinois. You won't be on the Zoom, but that's okay. Evanston, Illinois used recreational cannabis use legalization and the taxes received from it to be the first and only to date place that has active legislation about reparations for underserved persons from Evanston, Illinois. And how are they getting the reparations? They're using the tax received from the legalization of recreational cannabis use because it becomes a continuous stream of income. So I'm not here to say that all things related to substances are bad. There are ways to leverage it. Evanston, Illinois happened to be a place that you could look up about reparations in taxing cannabis. So we're going to keep moving forward. So dopamine. Whenever we're talking about substance, we have to talk about dopamine. It's critically important. So natural reward elevates dopamine levels. Food, sex. If we at baseline have 100, food, sex will bump us up 150, 200. The duration of time actually is about half an hour, maybe 45 minutes. So I can tell you right now, I am thinking, oh, I'm in Framingham. And I know not too far from Wayside is Chick-fil-A. And I like Polynesian sauce. I'm thinking about good food and I'm getting excited. My dopamine level is going up. Okay, so we all experience this. Now, nicotine, and this is where it becomes very problematic and challenging to actually help our clientele, right? So nicotine, let's just think about the Chick-fil-A that I mentioned. I apologize if I'm offending any individuals who don't eat chicken, don't eat beef. I'm just giving this as an example. Chick-fil-A, I gotta order, I gotta wait in line, I gotta prepare the dip, chew, swallow, and over half an hour to 45-minute period of time, my dopamine will rise, it will eventually go down. Nicotine, imagine a vape. Imagine a vape. Quick, and look at the time that it takes to get from 100, that's baseline, to 225. It's within 10 minutes. And so then you stop, and this is where a decade plus ago, you might see individuals that were quote unquote chain smokers, right? But now we kind of see chain vaping. Now the duration of time that the nicotine lasts and at that high of 225 dopamine is actually just about 15 minutes. So it's why when you start to engage with it and our clientele engage with it, it's very difficult to go your morning without engaging with it. It's so quick, it's in the palm of your hand. Now, morphine, opioids, think about this. I could do something that could bring me near 200, but now look how long it lasts. 4 hours of the euphoric feeling that I might experience when I have Polynesian sauce on my chicken nuggets. But now I get to do that without waiting in line, just by using a substance. It becomes difficult to think about doing other things. Cocaine. Now, nicotine 225, morphine 200, cocaine 350. You smoke 350. Duration of time that it lasts, 3 hours. And methamphetamine, the most difficult substance for us to treat. 1,000. I'm not advocating anyone experience what methamphetamine is, but think about whatever it is that you can think of that brings you joy. Whatever that is for you, methamphetamine will supersede that by logarithmic values. So you then see why it's very difficult to manage methamphetamine use disorder. And what we really do from a therapeutic standpoint is we try to give individuals super therapeutic doses of stimulants. So methylphenidates, i.e. Ritalin or Concerta, in the amphetamine world, Adderall, Vyvanse. And there are trials that help and have demonstrated that the medications, bupropion, can be helpful for methamphetamine use, but it is particularly challenging. Hold on. Let's see, 2 questions. I noticed that the dopamine line is not going below baseline. Does it go below baseline for extended use? And then is it helpful to name the things like coping skills likely can't match substance release rates? So first question, notice that the dopamine line doesn't go below baseline. Well, yes, because baseline for all of us, we're hovering broadly at 100. Now, the challenge is, remember that earlier slide, this idea of like reward, right? So I mentioned my kids as an example, the cookie will bring them reward. The challenge is when we engage in substances, nicotine, morphine, cocaine, methamphetamine, cannabis use disorder, and we keep bringing our dopamine up supraphysiologically, i.e. by some external thing, when we then remove that external thing because I want to take a tea break, or I don't want to engage because I recognize I can't function like I want to. Now, your normal way of getting your dopamine high or elevated is skewed. And so it's very difficult for you to bring it up. And so you feel depressed, not because you don't have any dopamine around, but you've been super physiologically elevating it. So now when you remove it, it's actually very difficult for your native neurotransmitter to emit dopamine. And so when I suggest to you go to do yoga or run or meditate, it takes significantly long periods of time, months to sometimes years, depending on the duration of the cannabis substance engagement, to rewire your ability to recognize and how to feel reward or joy without the substance. And then to the second question, is it helpful to name that things like coping skills likely can't match? Yes. So in the moment of the engagement with the substance, it is challenging. And this is why substance use treatment is not just one thing. It's not just medication. It's not just individual therapy. It's not just group therapy. It's a holistic wraparound, because we recognize any one of those things maybe can't match the substance that the individual can receive. And then a tea break is when, oh, yes. Yes, Steve is acknowledging, I happen to say tea breaks. So sometimes there are times where individuals are engaging in cannabis or THC very regularly, and they want to demonstrate it. No, I don't need to do this all the time. I'm going to take a break from it. So it's a tolerance break. Apologies for just using language that might not be known. So in terms of the behavioral response of substance use or severe substance use, in this case, i.e. addiction, there's a drug liking period. And if you don't have it, withdrawal and negative affect, i.e. your feelings don't feel great. And then you come back to the craving. And we see this pattern of, and apologies, I just like to engage. For kids with ADHD, is the neurobiological baseline low for dopamine? Why they have trouble stop activities that bring them joy, AKA dopamine, and extremely difficulty finding things that aren't particularly fun, enjoyable? Actually, this is a great question from Audrey. There are some elements of individuals that have ADHD that is in relationship to dopamine, but I'll say, for instance, youth who have ADHD, for instance, why can they engage in things like video games? Yes, there's dopamine, but also the video game is engaging multiple segments of their brain. That is classically why a kid that has ADHD can be kind of, well, ADHD hyperactive, let's just talk about that subtype, can be running around the room, doing multiple things. You might know adults that have multiple roles that they have, and they can think and engage, listen, they're doing all of it. And it's not because the dopamine, but it's just how their brain happens to be wired. And what the medication, let's say stimulants, do is actually not bring them more dopamine, but actually allows them to be able to focus, in this instance, on the tasks that are boring. So when you, classic example, you get someone that has ADHD, you give them, an assignment that they should be able to do. So you are 12, you likely know your times tables, and you give them 10 questions. They know the answers. You give them 10 questions, they have ADHD. By question 5, they'll start looking around because it's not engaging enough. Now, what's notable here is individuals that have ADHD and neurodevelopmental conditions, if they're not adequately addressed, are at greater risk of developing substance use disorder. In part, remember the substances, it rewires and skews your reward. So it is important. In reference to the slide that you're looking at and the image on the right-hand side, the substance use, you see this yo-yo effect, up and down, up and down, up and down. And although it says opioid, this actually is in relationship to most substances, up and down, up and down, up and down. Then there is going to be a period where they stop because they want to prove Steve wrong. Man, this guy, he comes here every week talking about, I can't stop. I'm gonna show this guy. And they can, and you can see here, it might be days, it might be weeks, but life is life. And there's going to be a stressor. And it's classically during that stressful period of time, if they don't have that wraparound, that person to call, or the skills that have been worked on, the grounding activities, it is far easier to then re-engage and be in quote unquote relapse. I'll give you a personal example here. Had a young adult, female, opioid use disorder, some other medical conditions, and she was on Suboxone at one point in time, and 2 years doing well, has a job, is going to school, not getting admitted to our inpatient unit, not getting admitted to the ICU where she had been admitted one time post-overdose, 2 years. And then we're engaging. And she's like, Dr. Simon, I don't really want to be on Suboxone anymore. And I'm like, I totally understand.
Wow.
I'm not sure if that's Amy saying wow to this or to something else, but hi, Amy. So 2 years doing quote unquote well by all quote unquote metrics, and says, I feel like I'm using it as a crutch. I can do this thing called life on my own. And we're working together, and she on her own accord is slowly tapering down. And at one point we get to 2 milligrams, basically one strip. And I'm like, you're at 2, let's just keep, at 2. But this is someone who's over 18, but they're engaged, and come back, and I stopped it. Again, they're still coming. And say, okay, probably not what we talked about, but you're an adult. A month later, engages again, and there's a classic phrase, I slipped up. And it's not that they really slipped up. What it was is the uncle had a heart attack that lives with them. And that was some stress in the household. So re-engagement with opioid. Now the individual didn't want to be on Suboxone, they wanted to be on something called naltrexone. And naltrexone is an opioid blocker. It does prevent overdose. However, you need to minimally be 7, but I would suggest, given the climate that exists in the New England area, if you're engaging in exogenous or street substances, there's a good chance that it's adulterated with other things. You probably need about 10 to 14 days of no opioid in your system before you can be given naltrexone. Otherwise, we then cause what we call precipitated withdrawal, i.e. you feel like SHIT, and I don't want you to feel like SHIT. Now, this 10-day period that we need before we could try to give the naltrexone could never be reached, because now you've re-engaged with the substance that takes a hold, and maybe you get to 2 days. But now, if you're talking about opioids, you actually have to somehow manage opioid withdrawal without any kind of medical support. If you're not in the hospital, that's very difficult to do individually. And so what happened? Many months without engagement of medication or any other kind of supports other than just like, our regular check-ins, and ended up getting inpatient because there was a period of time where they were suicidal. And then during the inpatient hospitalization, when you can get additional other supports, that's then when we could re-engage giving them Vivitrol. So again, managing clients, families that have these kind of struggles is difficult, but this is the pattern, and we know that it's a chronic condition that we're going to see this. So quick cannabis note. Cannabis does alter reward pathway. We have evidence here. So association of marijuana use with blunted nucleus accumbens response to the reward anticipation, i.e. individuals who engage with cannabis regularly, and regularly is daily to near daily over more than 3 months. In some other studies, chronic cannabis use is described as more than 50 times in a lifetime, depending on the study that was done. But in this case, more regular use, near daily, over many months. What do we find? That, so if you look at the left-hand side of the image, you see this GABA, and then you see the glutamate. Glutamate is our excitatory neurotransmitter. Excitatory neurotransmitter. And under normal conditions, oh, I know that we're going to go on vacation. I know that we're getting one of these one time, but it seems to happen 24 months in a row, one time bonuses. I know it's coming, I get excited. Glutamate is getting me excited. Chronic cannabis engagement. Recognize that GABA, which is our kind of calm down, and glutamate, they don't fire as normally as they should. And so we do recognize that individuals that have chronic cannabis use do have a blunted response to normative rewards. And then there's a question on the previous slide, on the previous slide, why do the up and down lines represent a person using occur more faster in relapse? Oh, so so for this particular image, right-hand side, they're referring to why does the relapse look like it's happening faster? So that portion of the image, if you note the orange boxes, it's actually in reference to heroin injection. So that's not specific to generalized substances, but specific to heroin injection. And I'll just say thank you. And so we do recognize that individuals that engage in substances that require needle use, it is less likely that they go many days without engaging in that form. To end at 12, we should take a short break at 11. This is Allison. You know, we're talking about anxiety. Her own anxiety she couldn't contain it.
My part of
we-
my job is time management, Dr.
We
Simon.
we will certainly take a break at 11 o'clock, which is in
11:10, 11:10,
15 or so minutes.
11:10 is the break time.
Okay. All right, so keep going. Now, chronic cannabis use. Now, of note, if folks find that this is not engaging, please put it in the chat. Again, I like active feedback. So chronic cannabis use alters intelligence. Average IQ from age 13 to 38, there have been studies that longitudinally look at what happens to individuals that engage in regular cannabis use and their IQ over time. And so what did they find? That the average IQ change for individuals who quote unquote never used basically stays the same. The average IQ is 100, basically stays at 100. Marijuana dependent, and the reason that the language here is dependent, this was published in 2012. So sometimes I have to acknowledge the language has shifted. But marijuana dependent, 3+ years, you can see it goes from the average of 99 down to 93. Now, 93 is still an average IQ. But now envision or imagine the patient or the client that you might engage, who when you get their neuropsych report, if they have a neuropsych report, their baseline IQ is at 87, which is low average. And I'm using 87 in part, I have a patient just like this that I got their neuropsych report, and they happen to also be chronically engaging cannabis. So 87, and that person continuously chronically engages with cannabis, and in theory gets a drop of 7 points. That's going to be significantly noticeable to that person, let alone to the system around them, particularly if they're in like an educational system. Because they're already starting at low average. Now you go 87, then chronically over many years, you're down to 80. It's going to impact your ability to do certain things. So again, when we identify youth, adolescents that are engaging with this, there are true life and physiologic consequences that happen to them. Now, cannabis and driving is dangerous. So what I want to identify, because I know this is a busy slide, if you look at the right-hand side, so i.e. the paper side, and you look at the title, recreational cannabis use impairs driving performance in the absence of acute intoxication, i.e., yeah, I smoked earlier today, but I don't think that I'm high right now. I can drive. That's what the title's saying. And what did they find? So now we look at the left-hand side, and if you can see my mouse, Allison, can you see my mouse? My mouse moving? Yes, okay. Left-hand side, the way to look at this is HC means healthy control. HC means healthy control. CU means cannabis use. CU means cannabis use. And then early, i.e. 3 group, early means the age group that we're talking about, adolescent, versus late use after 21. So healthy control, accidents, right? Number of pedestrian hits, healthy control, low. Cannabis use, high. These little 2 stars just mean that it's statistically significant. Healthy control, low. Early cannabis use, even higher than the general cannabis use. Accidents, okay? So pedestrians hit, accidents, collisions, cannabis use higher, early, even higher. Rule following, i.e. the number of missed stop signs, cannabis use higher, early cannabis use even higher. Rule following, number of stops at a red light, healthy control, they're able to recognize the red light and stop, yes. Healthy control, really able to recognize, yes. So cannabis use, struggling. Early cannabis, particularly struggling. Speed, number of speed exceedance. So i.e. the speed limit is 35, am I actually going 35? Cannabis use, higher. Early cannabis use, higher. Percentage of distance driven over the speed limit, both higher. Lateral movement, i.e. can I stay in the lane? Again, this is not during the period of acute intoxication, i.e. not when the person subjectively feels high. Lateral movement, crossing the line, both higher in regular and particularly elevated in early, and then lateral movement, distance driven out of the line. So when you meet that clientele that suggests, nah, I'm good, I'm not sure, we're good. Albert, in the case of the individual who eventually stopped the Suboxone use, but relapsed, in your opinion, do you think her recidivism is due to the stress situation in the house, or will you attribute it to quitting use of Suboxone? Oh no, I attributed it to the stress, i.e. the heart attack that the uncle experienced. If individuals are not exposed to stress, however, life is life, we're all going to be exposed to stress. If individuals are not exposed to stress, there's a good chance that non-re-engagement with a substance is very well possible, but life is life. There will be something that causes stress. It could be relationship related, it could be work related, it could be unexpected news, right? There's a whole host of reasons that something could, significantly cause a person's stress. And if they don't have the supports in place, they default to the thing that they believe is helpful, but long-term ends up not being helpful. And I can say that that person re-engaged with, again, naltrexone, so not even Suboxone, re-engaged naltrexone, went to a female only sober home, and is doing well. They're still engaged in care of me. And so they're not getting Suboxone right now. And they happen to not be engaging with opioid, but they are taking medication. They are, receiving treatment. But yeah, stress, in part because life is life, the stressor will undoubtedly happen. Now, cannabis withdrawal symptoms. So this is important. And I'll give you an example. I'm the on-call physician at Boston Children's Hospital in the emergency room. It's on a Saturday. I hear about a 17-year-old Haitian-American male boarding for inpatient. I was like, oh, well, what prompted them to come in? And they're like, oh, they fought at home with their father. I was like, just culturally, there's not a thing that happens in many Caribbean households. The notion that the son, irrespective of the age, is actually going to fisticuff with their father. So I was like, oh, inpatient. So I'm like, inpatient, that seems very high in terms of need. So I went to talk with the youth, and very remorseful, acknowledge that they don't, they don't want to really hurt their family. But when I asked about history, they had actually crashed the car. They had taken some items from a store. Again, prefrontal cortex, executive function, just like not online really. In part, they're taking things that their parents would actually buy them. So there's no need, justification to actually steal. And so I'm asking about the engagement with the dad that resulted on Thursday morning, i.e. dad walks in the room, hey, let's go, I gotta get you to school. Kid doesn't really want to engage. And the dad takes the video game device and is like, come on, man, we're gonna go. That caused significant, pushing, shoving. Eventually they called emergency, 911, got them in Children's. So I started asking questions about, and this was in March of this year. I started asking questions about substances. They're like, oh yeah, I smoke sometimes. I was like, okay, when's the last time you had a blunt? And they had told me the date because they knew it. They're like February 22nd. I was like, oh, why do you know that date? And they're like, oh, there was a party. That's just when the last time it was. I told you my session with the person, because I'm covering the ED, was in March. So I'm like, okay. And I have this cannabis withdrawal paper from Addictions, Connors the author, 2021. In my mind, I have this visual in my mind. I was like, oh, okay. And this is someone that had no prior formal psychiatric diagnoses, had never been on an inpatient unit, had never been in a program organization like ours. Right? It's just very atypical that a random 17-year-old male, let alone Haitian American male, Caribbean American male, would just fight their dad. And yet they had regularly engaged with cannabis. And they stopped on February 22nd because they just recognized that was the date. I'm seeing them in March. I was like, oh, and I literally go to the printer, print it out, and show them this. I was like, I wholly appreciate that you, don't want to engage in cannabis anymore. But it's likely actually why you're here now. In part, let's look. So this is after daily or near daily cannabis use for more than 3 months, and the person opts to stop. In week 1, so day 0.0, week 1, what's going to happen? Insomnia, so trouble sleeping, poor sleep, shakiness, sometimes it might feel like anxiety, decreased appetite, because classically cannabis increases your appetite. And then, sorry, very sensitive mouse, sweating chills, i.e. it's nighttime, I'm sweating, but I want the cover on, but then I also want the fan on, right? Just very uncomfortable. That's week 1. Most people actually just don't even want to experience that, don't want to feel that. So they're going to end up resulting with re-engagement. Week 2, what happens? Irritability, anxiety, restlessness, depressed mood. Why depressed mood? Because classically, you've been bumping up your dopamine. Now you don't have it. The things that should feel enjoyable to you is very difficult. Remember that blunted response? That's this. And week 3, really from week 2 on to week 3, anger and aggression. So what does that look like? It looks like a 17-year-old who classically has no real issue with his parents. Dad's trying to get him to go to school on time, takes the controller away. He's already irritable. What if you taking that from me? And dad's like, whoa, who do you think you're doing this to? And you get 2 guys who love each other, now pushing and shoving, pushing and shoving, pushing and shoving. Mom's like, what's going on? Little brother's crying. We're calling the ambulance. Now I meet them and I call and I say, hey, are you actually scared of him? No, but he can't be acting that way in the house. Wholly understand, got that. Has this ever really happened before? No. So okay, got it. I'm just curious, is there other family in the area? Yes, we got some cousins in Mattapan. Okay. Is it possible that he could go to Auntie's house for, Saturday, Sunday, and come home Sunday night? Oh, yeah, that's fine. Okay, well, you come, and I explained this because it's the cannabis withdrawal that resulted in the behavioral shift, that resulted in the fisticuffs that got him to the hospital. Yet, what does that look like? It looks like a Black male, behaviorally dysregulated, arguing. Somebody else is thinking, this needs to be inpatient. But I got more collateral information, talk with the actual provider who's my colleague that saw them the day before, talk with the parents, talk with the aunt, talk with the youth, realize, oh, this is actually substance use related. Now they're engaged in our clinic. No more, coming to the emergency room. Now, did he just stop substance use engagement, cannabis engagement altogether? No. However, we have a better understanding and his use is actually significantly reduced. And there's a question or a comment maybe. Are you aware of any studies or do you have experience regarding K2/Spice with anxiety, psychotic symptoms. Yes, you're talking about cannabis-induced psychosis. Yes, I do have studies. However, the context of what we're presenting here today, it was just about substance use and anxiety. So I apologize if there's things that you want more information on that I happen to not be sharing, but you can always email me, Kevin_Simon@waysideyouth.org. And I'm being cognizant, 10 minutes before the break, Allison is breathing sighs of relief right now. So regular cannabis engagement, again, when you stop, we have to be cognizant about what to tell the youth or the adolescent about what they are to experience and how can we mitigate these kind of withdrawal symptoms. And there are actual ways. So screening tools, we know them. Now, this is Sharon Levy, Oscar Buckstein. This is just to highlight that, yes, we should be screening. Yet, despite the fact that we should, the United States Preventive Task Force says still there's not enough information. So I always highlight this because the professional society said, no, actually you should screen. And the United States Preventive Task Force, they're very, very, very conservative and indicate, well, why do we screen? But we have a lot of evidence that indicates we should be screening. So here are some brief screeners. And as acknowledged by Stephen earlier, we use the craft here and probably using the craft 2.1. That was actually developed by John Knight, who was a developmental pediatrician at Boston Children's Hospital. He was a mentor to Sharon Levy, that other lady that I just showed. And Sharon has developed the S2BI, Screen to Brief Intervention, i.e. it's online and has fewer questions. So there are many questionnaires, there are many assessments, and I have time. We're just going to broadly look at substance use disorder criteria. And there are, I believe, 11 substances that kind of fall into this. So this is why I just use substance use, and you don't see it say nicotine use disorder, tobacco use disorder, alcohol use disorder, cannabis use disorder, opioid use disorder, hallucinogen use disorder. Any of these substances fall into it. Interesting enough, for the DSM-5, you don't see caffeine use disorder, but there is a caffeine withdrawal syndrome. So for those of you who do regularly engage in caffeine, I am one of them. When you actually stop, you do at times feel withdrawal, headache. So just FYI. Ooh, I look purple. I don't know if I look purple to you, but on my screen, I now look purple. I don't know what I did, but hey, we're in the Jetson land right now. So we're just gonna keep going. See, Allison, well, this is in vivo processing because I look odd, but I'm not gonna feel too anxious about it. We're just gonna keep going. I dig it. And it's Mars, yes. Mars, of course you dig it. Look at it. All right, so substance use disorder criteria. So I broadly shifted into the C's of addiction. And when I say addiction, I'm really referencing severe substance use disorder. So craving and preoccupation, compulsive substance use and engagement, loss of control over the substance use or engagement, continued use of the substance despite the harms, and that harm being physiologically or emotionally, and chronic maladaptive behavior associated with the use. Now, this is supposed to be a problematic pattern, and I appreciate the person who earlier referenced this idea of non-problematic, right? Because in the DSM, it says problematic pattern of substance use leading to clinically significant impairment or distress as manifested by 2 of the following over a 12-month period. Now, this is where it's very difficult in our patient client population because we're often talking about adolescents. And truth be told, the DSM-5 criteria for substance use disorder is validated on adults. And if I meet a 15-year-old who's engaging in, for instance, cannabis or engaging in nicotine vaping, probably not going to wait the full 12 months to suggest that they actually have a substance use disorder. But what is it that we need to be asking about? These 11 criteria. Is the use in larger amount or for a longer than intended period of time? Is the desire or unsuccessful effort to cut down on the use? Has there been a great deal time using or recovering from the engagement? Craving or strong urge to use? So again, we just need two, and you've already are in the mild. Social impairment, role obligation. Well, what's the responsibility of an adolescent? School, maybe chores, maybe be on the basketball team or the soccer team or some club. Continued use despite the social interpersonal problem, i.e. you keep getting in fights with mom or dad or grandma or whoever the guardian is. You're losing friends, you're becoming socially reclusive, sacrificing activities to use or because of the use, i.e. oh, it was just Thanksgiving. Yeah, I don't want to go to grandma's. I'm good. Y'all can go. And they stay back and engage inappropriately. Risky use in situations where it's hazardous. Again, think about the adult while driving is the classic kind of question. Even on the craft, that's the question. But I'd say it's dangerous when your prefrontal cortex is not fully developed to be engaging in regular use. Continued use despite the knowledge of the physical or emotional circumstances. So someone asked about, any said about K2, spice, cannabis-induced psychosis. Well, we know, and I have patients that have experienced cannabis-induced psychosis. And despite the fact that they landed themselves in a hospital, don't believe that the cannabis can do it again. It's like, well, it's not happening now because, well, now we're on Risperdal, or now we're on olanzapine. And so sometimes these patients are getting high doses of antipsychotic to mitigate the psychosis that can happen from the cannabis, but they're still willing and wanting to engage. Neuroadaptive or physiologic shifts, tolerance or withdrawal tolerance, i.e., oh, I need to, let's talk about cannabis for a second. They went from a blunt to a vape. They went from a vape to using concentrate or wax, right? So they need higher and higher concentrations to achieve this effect that they want. And then the withdrawal, they don't have it anymore, and they're experiencing those negative symptoms that we talked about over that timeline when they stop engaging. So 2 or 3 of these symptoms, you're at mild X, name the substance use disorder. 4 to 5, you're at moderate X, name the substance use disorder. 6 or more, you're at severe X, name the substance use disorder. And classically, severe is what people are thinking about when they think about addiction. And can you share? Oh, yes. Someone wants to take a screenshot. That's what I'm suspecting. Of course I can. There you go. And we'll leave it for more than 2 seconds. But hopefully those who want a screenshot, also, we're all colleagues. We can make sure we get you this so that way you have it. You don't have to take a screenshot. You can have it saved on your file. We'll put it on a OneDrive somewhere. Gamel is like the maestro of IT, which is why I look purple for some reason. All right, so making the diagnosis. Allison, where are we? 1 minute before break?
Yes.
All right,
Wrap
making
up.
the diagnosis.
Wrap up.
All right, essentially, take a complete history, consider co-occurring substance use disorder. But for right now, let's take a break. You've been engaged, you've been putting questions, comments in the chat. I love it. And we'll be back. And how long
So,
is the break?
We're just going to take a short break. We are done at 12, not 12:30. I think the original email was at 12:30. We're done at 12 today.
No problem, no problem.
And we're just going to take a quick 5-minute break. When we come back, I don't know, Dr. Simon, if you have a couple of closing words, but we do have 2 colleagues who are on the training today who have consults that they're going to do with Dr. Simon. So I'm going to share the content. I'm going to share the consult write-ups. I sent them by email earlier, but I'm also going to put them in the chat so that people have them to look at. And also those staff. So Travis from the young adult program, and then Jay from Milford Community Services are going to share a little bit about some clients they're working with, and Dr. Simon's going to offer some consult with them. So that's what's coming up.
Okay.
Perfect. So quick 5 minutes.
And I'm gonna see if I turn my camera off and turn it back on, if I come back in normal color.
I know, it was very, very strange. Better.
We're back,
Yeah, you're back.
live and in color.
I know, that was a new phenomenon. I've never seen that. Never seen that.
And how many, oh, I can open up so I can see. more.
Yeah, so we have two, Travis is scheduled to go first, and then Jay second.
Oh, yeah, I was actually referencing how many folks are still with us.
Oh, yeah, it was 100, right now
170.
175.
Okay.
So I think 180, we're up at 187.
And, if folks have questions while we're waiting, please put it in the chat. I'm gonna stop sharing for a second. Hello. Oh, apparently so. So while we're waiting, I think it's appropriate to keep the mood. And Allison will let us know when we need to start.
Okay, we're gonna get started. Dr. Simon, you're gonna wrap up, right?
Yes,
Okay,
and
perfect.
you all can see my screen again, yes?
Yes.
Okay, so this last segment is, and we have till 12, Allison?
Well, yes, this training ends at 12, but
Yes,
two
there's
staff ready to go.
Yes.
So,
So I just want to be thorough here. So apologies at the briefness of this. In reference to which came first is often very difficult to actually assess. Consent in terms of treatment, you all are very well familiar, but code of ethics obviously get consent from the youth or assent, depending on age. In the state of Massachusetts, if you're 12 or older and want to get treatment for substances, you actually can without requiring parental engagement. In terms of behavioral interventions, obviously motivational enhancement therapy, family-based therapies like parent management therapy, multi-system therapy, behavioral therapy, CBT, cognitive community reinforcement approaches are some of them. Purpose of the family involvement, learn more about the child and family. All this you all know, given where we work, so I'm not going to belabor the point here. And hopefully it's actually to decrease the family resistance to being engaged in, with treatment, let alone the youth engagement. And there is evidence that having family involvement in adolescents that have co-occurring conditions is more helpful. So here are the C's of parent guidance that we often reference. So cash, i.e. don't do it. There's very few places that I can think of that a youth needs to actually have cash. And so debit or credit card actually should be appropriate, i.e. you need a traceable document receipt. Cars are a privilege, right? Or access to cars is privilege, access to cell phones are privileges. Chores should be used as incentives. Communication, keep it open, frame. So even when those youth families are engaged with me, and let's say cannabis or some substances continuing to be utilized, and we're using urine toxicology to recognize the level, persistent ongoing use, but let's say the level is actually going down, can be still utilized as a way of the parent demonstrating that, okay, you're going in the right direction. Here's the reward for going in said right direction. Parents should know the companions, their friends and peers. Obviously, social media is very difficult. And then curfew, it should be that youth have a curfew. Personal example here, had a family, youth is 16 years old, it's during the summertime, and the dad's like, oh, he comes home after 12, he's smelling alcohol. And I'm like, what's the curfew? And they're like 12. I was like, well, why is it 12? And really out of nowhere, they're just like, actually, we don't know. And I literally in real time was like, I could tell you what the average curfew is of 16-year-old, but let's just Google average curfew of a 16-year-old in the United States. And it was 9, 10 o'clock. I was like, all right, let's make it 10 o'clock. In part, there's really no reason somebody who's adolescent needs to be out after 11. Now, if they went to a concert or the one-time Fenway game, that's understandable, but just randomly on a Tuesday, Wednesday, good odds that they actually should be home. So these are things that we kind of work on in parental guidance over time. If evidence-informed pharmacologic interventions, we have many. This is going to be very quick in reference to my prescriber colleagues. There's all these algorithms. And so I just want to make sure that I'm thoroughly going through everything. Obviously, adequate assessment needs to be done. These are SSRIs. You should try an SSRI like a sertraline, or that's Zoloft, or fluoxetine, that's Prozac. And there's justification as to why. And again, I will send these slides out so everyone has access to them. The reason you see the boxes over pregabalin, it actually is a controlled medication. Not to say that you can't have an instance where we need to use pregabalin, but odds are if it is being used, it should be used in a very controlled way. The same thing with benzodiazepines. Again, your Ativan or Xanax of the world. if you've tried the SSRI, it hasn't worked. You've tried to do duloxetine, that hasn't worked. We actually have others. You should potentially try buspirone, hydroxyzine, bupropion, venlafaxine. You got a partial response, hydroxyzine. So there's many ways to get at why is it that we should use which medications. So just broadly, antipsychotics for psychotic disorders, bipolar for mood disorders, depression, sorry, so sensitive. Depression, SSRIs or SNRIs, anxiety, SSRIs and SNRIs, alcohol use disorder, naltrexone, opioid use disorder, naltrexone, methadone, buprenorphine, nicotine use disorder, bupropion, nicotine replacement. Interesting enough, for nicotine use disorder, classically 2 forms of NRT or nicotine replacement is better than 1. So oftentimes I might hear a use say, oh yeah, I've tried the gum before, but they're not even chewing and parking, i.e. using the gum correctly. Or they put the patch on, but they haven't actually let it stay on for the full duration of 10 hours. If you do those 2 correctly, it actually might be very helpful. And then there is evidence for substance use disorders in adolescents. We're not going to go through all of these, but this is just to say that there are studies. So AUD, alcohol use disorder, naltrexone actually decreases drinking and heavy drinking in the adolescent age range. You can see here age range 15 to 19 years. So there are many studies: tobacco use disorder, nicotine replacement, tobacco use disorder, nicotine replacement. These are just the different trials that have demonstrated there is benefit to appropriately engaging the youth in targeted treatment. Again, tobacco use disorder, CUD, so cannabis use disorder, NAC or N-acetylcysteine was demonstrated by Kevin Gray. He's out of MUSC, Medical University of South Carolina. It had 116 treatment-seeking adolescents who at the time met DSM-4 criteria for cannabis dependence, 13 to 21. And they got NAC, 1,200 milligrams twice a day, i.e. 2,400 milligrams. NAC at one point was a supplement. You do have to get it prescribed now. And NAC individuals, so they got NAC plus brief cessation therapy, less than 10 minutes, regularly. And the NAC group had twice the odds, my mouse is hiding, twice the odds of submitting a negative urine cannabinoid test, i.e. negative urine drug test. Topiramate, not as strong of the evidence. Opioid use disorder, buprenorphine plus naloxone, that's i.e. Suboxone. And then even methamphetamine use disorder, that's for where we get the bupropion. So we have a lot of evidence, family feedback. So just want to highlight this in part because people can think this is so hard. It is really hard. The work is hard. Here's an email that I got from a parent a year ago, or this year, 1 year ago. She's acknowledging, hello all, 1 year ago today, we found out that he was having serious substance issues. We sat in the ER with him for 10 days. He cursed us out, refused to take his belt off, refused to pee, the list goes on. This morning, he is asleep upstairs. He went to school all week. We made cheesy potatoes together on Thursday night for school potluck. He's working regularly at Shake Shack. And actually, for the first time in a few years, said the words, I love you, last week. I'm not being hyperbolic when I say I just don't think we'd be here if it weren't for you all. You all are amazing and have helped us navigate what, to me, has felt like a totally insane nightmare. Dr. Simon, in particular, has very, very, very slowly and patiently taught me that he changing is as much about me changing. Took me a long time to figure that out and listen, but I think I'm on the right track. Thank you, thank you, thank you. And know that you are doing amazing work in this world with gratitude, parents. So I'll stop there. Oh, yes. And take the cases that our colleagues have prepared. So who's up first?
Travis, are you ready to go?
Yeah, I can
Okay,
start.
perfect.
Do you want me to share? I wrote something, I think I sent it to Steve, or I can just read it off.
Yeah, so it's
You could just read it.
you can just read
Okay.
it, and it's also in the chat. Right around the break, I posted the 2 consult write-ups in the chat, so people can click on that as well. But Travis, yeah, verbally.
Okay. So TS is an 18-year-old female. She lives at Henry Street, our staff department component. She is a senior in high school. She's doing well. She attends school most days without issue. Like there's a few that she skips, but she's pretty consistent in school. She presents with risky sexual behaviors in the community and dates multiple men, like more than 10 years older than her. She uses marijuana and does not take any psych medications. She's diagnosed with unspecified mood disorder and ADHD. TS most problematic behavior is she uses hard substances, crack cocaine, and more recently heroin. She does not use hard drugs consistently. It's more sporadic, and she typically will start using when she has unstructured time. Like it really all started on summer break from school. There's a 2-week period where TS skipped school as well and used during that time. TS does not work consistently. When she was working, she was spending all of her money on substances. Other than the substance use, TS is incredibly respectful of staff and follows all health rules. She is receptive to help. I know recently reached out to Steve to speak with him, and she does listen to staff when we notice that she's using, and we try to work with her to reduce her use. So she usually listens to us or stops altogether, but it's definitely an ongoing issue that she kind of steps in and out of. So the big concern is, since she's not using consistently, especially with the heroin use, like an overdose or something of that nature. So.
Yeah, so one, thank you, Travis, for sharing about T. And I'll answer the question, Lou, after responding to Travis. So the work that you all are doing engaging T, one, just should be commended. In reference to approaching a holistic treatment plan. So one, continuing to engage with her is one paramount. In part, she clearly must feel trust in the relationship that she has with the staffers that are in the program. From a system standpoint, I would make a referral to ASAP, Adolescent Substance Use and Addiction Program at Boston Children's Hospital. How would I make a referral? I might call 617-355-2727. Again, that's 617-355-2727. And I believe you suggested that she's 18. ASAP at Boston Children's Hospital accepts new patients up until 20 and 11 months, i.e. right before 21. However, when a person gets engaged with ASAP, they can continue their engagement with ASAP after 21. And so I'm one of the clinicians provides at ASAP, and I have patients who are 24, 25, but they started again before they were 20. In reference to T and the heroin, and it feels like it's sporadic. In part, maybe it's sporadic because, again, that they're not working. And so the accessibility to it might be vis-a-vis engagement with older individuals in appropriate ways. And so from a harm reduction / medication to be preventative of an opioid overdose, it would be highly, highly recommended that T, from a pharmacologic standpoint, receive naltrexone. In part, naltrexone prevents, we have a lot of evidence about this, prevents overdose. Naltrexone prevents overdose. And so individuals who are engaging in quote unquote sporadic use may not necessarily need to be on a buprenorphine, i.e. Suboxone, certainly may not need to be on methadone, but naltrexone can be an oral medication that they take that prevents overdose. If we are working with the individual and recognize that the sporadic use is actually not as sporadic as we think, maybe we can have conversations about other forms of pharmacologic intervention. The person appropriately reached out to us and thought to himself, hey, I want to talk to Steve. That's appropriate. And in reference to trying to do as much as we can for T, when working with ASAP, they would undoubtedly work with the team that is working with T, such that T gets an individual provider. If T were to have guardians that wanted to be involved, the guardian could get parent guidance sessions, could get pharmacologic management, for instance, like the naltrexone, minimally from a preventative standpoint, preventing overdose. And if there are other things, which there likely are, in terms of the ADHD or other things like anxiety, that can also be begun to be approached. And because T is over 18, need to obviously have their engagement in that kind of process. But that's what I would think about from like a what could we do today standpoint. And I can tell you that if somebody is engaging in heroin, and this is actually for most systems, when someone's engaging in heroin and ASAP is notified, they're up triaged, in part because of the severity of things like heroin, other opioids, fentanyl. So if a generic person calls and they want to eat evaluation and they do not identify that heroin or opioid is the concern, they just get queued on the wait list like any other system would queue on a wait list. If they've identified that heroin is part of the concern, they get up triaged, in part because we want to ensure that the medications that we know are helpful get to the person. They still are going to need to do all the other things, but we want to get that. And I can tell you, we just had someone who is 17 years old, has been engaging opioids for a very long time, i.e. since 14 years old. And they on their own accord wanted to get on Suboxone, and we helped make that happen even over the weekend. So that would be my suggestion for T. Oh, well, Sebastian, if you don't have access to the chart or the chat, it's in there, but I will repeat it. So ASAP is 617-355-2727. I think it's technically 617-355 ASAP. ASAP is 2727. And if you're somebody who is so 18, you could call on behalf of that person, but the person, because of their age, the legality, they would, the intake coordinator would provide that person with release of information forms. They could certainly put Travis Hinton down. They could certainly put Wayside Youth, which then enables us to, in theory, talk to anybody that's at Wayside. So there likely will be need of the program to help the youth feel comfortable taking this kind of initiative, but we can ensure that happens. And then I think there's another case.
So I just want to make sure, Travis, you didn't have any last minute questions or comments, right? So moving on, Jay Cohen is the second presenter.
Jay, where are you, Jay? Oh, I see Jay.
Okay, so this is a client that came to me as a younger child, as outpatient, left for a couple of years, and then came back as an IHT case as a young teenager. He had always been there's always been a discrepancy in his diagnosis. I believe he has strong elements of ASD. He was always tested sub-threshold, but extremely high levels of anxiety. His father passed away when he was 4 weeks old. His mom always struggled not only with that, but Joey has never been an easy child. Highly disengaged, very manipulative, pressure, really high pressure on mom, and never really adapted to school, but also very much misinterprets almost everything. Like he believed that he was working very hard in school. He was really doing about a quarter, under his IEP, he was doing about a quarter of the work of his peers. But this is kind of his perspective on just about everything. And he started to engage in marijuana use with, he never had friends. It was always very difficult for him, even kids in the neighborhood, he would misinterpret, there was always conflict. He actually had a best friend when he was in about 9th grade, who then moved away. But his mom would drive an hour and a half to drop him off on the weekends. So he started engaging in marijuana use with this peer. When COVID hit, Joey stopped going to school. He stopped doing online. He was put into a therapeutic school placement eventually, and still would barely attend. And as you're doing your presentation, Dr. Simon, I'm checking off all these boxes, of course. Monday mornings were miserable. He was always sick. He was throwing up. He had a lot of somatic illness. He was fine on the weekends. He was sick on Mondays. The marijuana use escalated to the point where he was smoking multiple times a day. His mom was extremely anxious because they're in federally subsidized housing, and if he gets into trouble, they could become homeless. So there was a lot of tension in the house. And then she discovered that Joey stole several $1,000s from her. And at that point, she forced him to go to drug rehab. He went it was Thanksgiving last year. He was in for a little bit less than a month. He was the youngest in the program by a long shot. He's now 19, so he was in the adult treatment, and most of the people there were older adults. So it was difficult, but he made it. He actually made several connections. They kind of saw him as their in kind of a parent-child, and so he got a lot of support. When he got out, he abstained from substances for months, although he would use that as a, when he and his mom were fighting or arguing, it would be like, what are you trying to make me do marijuana again? Right? In conversations with him, trying to get him to, before he went to rehab, his comments would be, it's the only thing that works to help me with my anxiety. And of course, my concern was that he, and this was an issue shared with Tiago, was that Joey really was very reluctant to do almost anything positive in his life. He really avoids almost everything. And it was very, very tough to get him to use self-supports to minimize the anxiety that he was feeling from the other parts of his life. So he has resumed smoking. What he reports is very occasionally. His best friend also went to rehab and has been clean now for close to a year. They do not smoke. He says they do not smoke together. He has made one other friend since then that he does smoke with, but only sees him about once a month. So that's where we are. He is transitioning to adult services soon. And part of my recommendations continue to be for him to especially be very aware of this as a possible problem as a relapse issue.
Got it. Well,
is there any more information that you need from me?
No. This is a very good summary, and thank you for having worked with him for what sounds like several years, even when he's left and come back. In terms of, obviously I have not, formally met Joey. However, we do recognize that a number of youth who, again, have what we'll just broadly say is neurodevelopmental things are susceptible for experiencing anxiety, let alone susceptible to experiencing substance use disorder or substance use engagement. To think about him for a second in this idea of like, we're not sure what the diagnosis is it autism or something else that's on the spectrum? We do recognize that, right? So this idea of social reciprocity, meaning knowing how to engage with people, reading cues, something that particularly should happen around the adolescent age range, i.e. abstract thinking. You said this joke, but there was a coy way that you said it, so I'm supposed to interpret that. Individuals that have autism disorder, let alone individuals that have social pragmatic communication disorder, let alone individuals that have non-verbal learning disorder, all struggle with this idea of communication. And if the 504 plan that shifts into the IEP or individual educational plan isn't accommodating for that, we're missing the boat, right? And so it could very well be that, again, something within that realm, yes, would have been helpful to engage in, social group therapy earlier on, but we're here now and today. In reference to what you're doing, again, the engagement, motivational interviewing, encouraging him to minimize engagement with the cannabis is appropriate. I had referenced this idea of N-acetylcysteine, and this again would be something that could be prescribed. And even Joey could get referred to ASAP. Although again, at his age, does he want to be engaged? There isn't concomitant use of other substances. So he still would be on the queue to get a formal evaluation, and any kind of supports that are present with him could get help. But that support likely would have to help him through that kind of earlier process of filling out the forms and so forth. I want to highlight the N-acetylcysteine, and so I'm going to share my screen and I'm going to share a paper that is important, perhaps, in this case. So it says effectiveness of N-acetylcysteine, i.e. NAC, in autism spectrum disorder. I'm not saying that Joey has autism spectrum disorder, but he has something that relates to this social reciprocity challenge. And what does this paper say? So it notes currently pharmaceutical treatment options for autism spectrum disorder are limited. Brain glutamatergic glutamate. Dysregulation is observed in autism spectrum disorder, but many other conditions, OCD, i.e. one of the anxieties, N-acetylcysteine, which can be converted vis-a-vis a biochemical process known glutathione, and subsequently release glutamate into the extracellular space, and thus reduce glutamatergic transmission, i.e. this dysregulation that's happening with glutamate can actually potentially get regulated by giving N-acetylcysteine. That's not the point. What I do want to highlight here is vis-a-vis a meta-analysis, i.e. looking at many studies that had NAC or N-acetylcysteine as the intervention. What did they find? So data synthesis, after 8 to 12 weeks of NAC supplementation, the pooled results of 3 trials revealed significant improvement in hyperactivity. That's not the important part for Joey, but it might be important for others. Regarding social responsiveness scale, the pool results of 2 trials show significant improvement in social awareness after 8 to 12 weeks of NAC supplementation. Now, I'm not here in any way, shape, form believing that, oh yes, let's just give him 8 to 12 weeks of NAC at 1,200 milligrams BID and problem solved. No, I'm just highlighting that NAC, amongst other things, could be an option that Joey could even utilize now, in addition to other supports. but IEP, appropriate neuropsychological evaluation, I don't know what it was or was not done. In terms of the transition to adult programming, right? So ensuring that, yes, our appropriate DDS application is filed, the appropriate diagnoses are highlighted, and hopefully, the fact that he's been receiving services now, he does then receive services as an adult. It would be probably appropriate to try, it seems like there's a good relationship here with him and you, right? Try to have conversation with he, guardian, i.e. mom, at least before he was 18, about potential types of legal documentation that might be helpful for him to fill out with mom. I'm not aware if he's working or not working. Does he need a conservatorship or not? These would be things to kind of think about, because there may become a scenario where we recognize he's working, but then he's not saving anything, or he's not utilizing the resources in an appropriate way. So conservatorship can help there. There are a number of behavioral interventions, systematic intervention, and then yes, some pharmacologic intervention, i.e. it could be NAC. If he does have ADHD, which it potentially sounds like he might have, he could have medication that helps him better attend to the activity that he should be doing. So there are ways to, what I'll say is pivot Joey in a better direction if he feels like he's not going in the direction that he wants to be going. So that's what I would say, Jay. And again, I appreciate you sharing about him, and again, the engagement you've been having with him and the family over several years. So any general questions folks have, you can put it in the chat. We have 10 minutes of time. Yeah, so if there's a slide that you want a photo of, although again, you're going to get the slides, or you just have general questions about substances, anxiety, and really anything. We are opening up the floor.
Dr. Simon, I have a question, or
Yes.
just a comment. I think a theme we hear a lot from youth and young adults is that marijuana is the most effective thing that they found to manage anxiety. And, medication, they may have tried other medications and whatnot. So I wonder if you could talk a little bit just about, I think you gave a lot of really helpful ways to think about that and maybe present it, but can you just talk a little bit more generally about the conversations you might have with a youth who presents and sort of has that
Yeah.
that idea, and the reality might be it actually may be somewhat effective, but they've sort of associated marijuana use with and sort of justify it by how it impacts their anxiety.
Yeah, and I'm just gonna answer Anna's question. I'm not familiar with something in the central Mass area. However, ASAP does provide services to the whole entire state, in part because if the chief concern of the family is substance use in our state, you can receive services. And so unlike other specialty clinics that exist at Boston Children's Hospital that might require your pediatrician to exist within the Boston Children's Network, if the concern is substance use disorder, you can come from anywhere. So we have patients from Billerica, from Worcester, from the South Shore, from the North Shore. It's anywhere. In reference to Allison's question, and someone is piggybacking off of Allison to say, what should we be saying to youth saying they plan to get medical marijuana cards? So in reference to youth who suggest that cannabis is the thing that is helpful to them, I would lean on the motivational interviewing components of our work, right? And so if it is the thing that is supposedly helpful to them, well, there's many ways that we can inquire and help them recognize and avail to themselves that, oh, wait a minute, it's not actually as helpful as I thought it was. i.e., again, now if somebody is engaged in school, doing well in terms of the relationships at home, academically, they're doing well for whatever program they're in, traditional school, alternative school, therapeutic school, engage in the extracurriculars that they want to be engaged in, and they happen to use cannabis. But again, we go through those criteria, and this is I'm speaking to the clinicians here, not in reference to how the youth might think. Perhaps there's non-problematic engagement, perhaps. But if we look at the criteria and we assess and we hear from the youth who doesn't realize that they're telling you criteria, and we hear from the parent or the guardian or the system that there's challenges, right? When we now talk to the actual youth about engagement with the cannabis, you should ask them, okay, well, how does it help? So it helps with my anxiety. Does it help with anxiety so much that you're able to participate in school? Or does it actually result in, like what Jay mentioned, school avoidance? Despite the fact that there's engagement with the cannabis, right? Because if it is helpful, then it should be helpful to enable you to do the things that we would anticipate any 15, 16, 17-year-old, 18-year-old to do, right? So you get to ask them that question. Oh, well, if it's helpful, how are you doing in your social realm, right? Friendship should be something that is happening around the adolescent age range. The friends that you have kind of do predict the kind of company that you keep, right? How are your friends doing? So there's always ways to do MI in getting them to actually avail to themselves about, wait a minute, maybe not so much. I'll give you an example. 19-year-old freshman at Northeastern brings cannabis home because cannabis is the thing that he struggles with. This is actually the same youth that ended up in the emergency room, and I ended up saying, hey, you don't need to be an inpatient unit. So cannabis, mom looks in his bag, finds it, grounds him. He's frustrated. He holds the car keys, i.e. preventing mom from having access to the car. There's challenges. And so when I'm talking with them, I'm like, okay, what's the house rule? Don't bring it in the home. You weren't born with it. Mom didn't give it to you. Now, could you, I don't know, leave it in the backyard or leave it under some rock? You could, but she said, don't bring it in the home. So that's your decision that you made, and it's her home. So she gets to make the rules. So there can be consequences as a result of making certain decisions. And we got to talk about consequences versus punishment. A consequence, if I don't put my notes in on time, I get a consequence. If I don't bill on time, I get a consequence, right? We're all held to consequences. And so we talk about consequences in the event that the parent is actually trying to hold the line. And then again, I would talk about symptomology. This idea of it helps, again, help you sleep. Well, just usually, we should be all be able to sleep, irrespective of having a substance in our system. So the short answer and long answer is MI is the way to get the youth to actually avail and talk about it. Because, I often do say, on a scale of 0 to 10, 0 being, Dr. Simon, get the hell out of my face, I'm never going to change. 10 being, I would do anything under the sun, but it's just so damn hard. Okay, where are you on your willingness, your own motivation to want to shift how you're engaging with it? And some do tell me, all right, 3. I'm like, okay, 3. Why isn't it a 2? Why isn't it a 1? And some say 8. Like, okay, 8. Okay, so you get to know for them where they are. And this is where if you're in a program and you're getting urine results, and not urine results to be punitive, but urine results to be actually helpful to them, because sometimes they think they're engaging just with cannabis and there's other things, i.e. it's adulterated. And I've been able to help individuals, okay, I don't know where you're going, but you shouldn't be going to that, provider, i.e. the person they're buying it from. Go somewhere else, because other things are showing up. That's harm reduction. So oftentimes they will say there's something that they do want to shift. And you try to anchor on that and help them anchor on that. And shift could be, and I have a 16-year-old, shift could be, okay, I'll only use it after 6 p.m. They were using it many times before 6 p.m. So getting them to use it after 6 p.m. I didn't get them to 0, but after 6 p.m. is better than you wake up and you got to use it within an hour. So there's always something to kind of move towards that helps them be a better version of themselves. And then somebody,
Dr. Simon, you can
Yes.
you can do one more because you have to be at your next training.
yeah, I see. It says one frustration is that it can take a very long time to try different medications and dealing with insurance companies to pay for med. It often requires psychiatrists, youth to try XYZ drug first serve. Those drugs can be more immediate for feeling less anxious. Any suggestion on managing a slow system? Yes. So this whole thing, life is not fast. And we have to help them realize that there are no immediate fixes. Right, and then that's actually just true. There's no quick fix to any of this. Doing the right thing often might feel and be actually difficult. But being with the person, experiencing that transfer, experiencing that counter transfer with them, and being with them can be helpful. And in terms of the medication, yes, unfortunately, a lot of times in the community, we're not optimizing medications in the right way. So for instance, I know people will say, oh, SSRIs are supposed to take 4 to 6 weeks. Actually, if you dose it appropriately with the right person, it actually you can find residualization of symptoms within 2 weeks. But are we even open, Caribbean family, certain cultures, they don't even want to talk about medication for several months. And, sometimes that's okay. I can't force anyone to do something that they don't want to do, even though I might have all the evidence in the world that says, hey, this would work. But that is part of our actual profession in human services, is to help people manage all these emotions. But it's 12 and we end on time. So really, I appreciate everyone that's been here and engaged. We'll get these slides to you. And yeah,
Thank you,
awesome
Dr.
to be here.
Simon. If people can take a minute to fill out the survey, Amy put the link in. We really appreciate your feedback. We'll be thinking about a second training, substance use training in the spring. So if there are topics that you're interested in, please include them in the training feedback or send Steve or Dr. Simon or I an email, and we'll be thinking about what to put on deck for the spring. Thank you, Dr. Simon, for your time and for sharing.
Thanks,
for
folks.
John,
Please fill out the
yeah.
survey.
Yeah, and for John and Travis, thank you for sharing about your clients that you're working with.
Thank you, everybody.
Thanks, everyone.